Hello, welcome back to our discussion series. Today we are discussing the FMGE previous year question paper, and this is the discussion. Today we are discussing the June 2024 question paper. First question from the anesthesia part, they are asking which of the following has an inhalation anesthetic has a blood gas coefficient, blood gas partition coefficient similar to the nitrous oxide. We have to know what is blood gas partition coefficient. It reflects the solubility of the inhalation anesthetic in the blood. So, if the partition coefficient, the blood gas partition coefficient is less, that means the solubility will be less. If the solubility will be less, the anesthetic will be easily available for reaching the brain, and it acts faster. So if the coefficient is less, solubility will be less and it will act fast. And uh, they're asking which of the following inhalation anesthetic has a blood gas partition coefficient similar to nitrous oxide. So we have to know what is the blood gas coefficient of the nitrous oxide. Uh, so the blood gas partition coefficient of nitrous oxide is 0.47. Looking for the desflurane, it is 0.42, and sevoflurane is 0.65, and isoflurane is 1.4, and halothane is 2.3. So which has the lowest blood gas partition coefficient? It is desflurane, which has 4.42, and it is similar to the blood gas coefficient of the nitrous oxide. The question was which of the following has the blood gas coefficient similar to nitrous oxide? So the answer is desflurane. So the answer is desflurane. Moving on to the next question. In epidural anesthesia, which of the following layers is least likely to be punctured? Which is least likely to be punctured means which are not punctured, or the least chance to be get punctured during the post procedure of epidural anesthesia. So we have to know which are the layers punctured during the epidural anesthesia. So, first layer is the skin and subcutaneous tissue. First, the skin and subcutaneous tissue. Then we are cutting the supraspinous ligament. This is the supraspinous ligament. Next, they are cutting the this syringe is piercing the infraspinous ligament. Then it cut the ligament of flava, and it reached the epidural space. The aim of epidural anesthesia is to uh, reach the epidural space and injecting the anesthetic agent in the epidural space. So we reach the epidural space. Next, the layer is the dura mater, then arachnoid mater. So it is deeper to the this dura and arachnoid mater is deep to the epidural space. This is deep to the epidural space. So we are least likely to be punctured is dura, arachnoid matter, then the quad equine, then the posterior ligament, a posterior longitudinal ligament, then the and intervertebral space and the vertebral bodies are least likely to be punctured. So the answer to the question is arachnoid matter, or if dura matter, these are least likely to be punctured. First, we puncture this supraspinous ligament, then infraspinous, then ligament of flava, and we reach the epidural space. And the next layer is the arachnoid matter. So it is least likely to be get punctured. So moving on to the next question. Which of the following which muscle movements are related to the abducens nerve? We know the extraocular muscles. There are 7 extraocular muscles like levator patabrae superioris, the superior oblique, the inferior oblique. We can see the levator patabrae superioris. Then the superior oblique, then inferior oblique, and the superior rectus, inferior rectus, then the medial rectus shaded as pink color, and then the lateral rectus, this green color. These are the muscles. Seven extraocular muscles, and all the extraocular muscles except superior oblique, lateral rectus, and are supplied by the cranial nerve 3. That is the oculomotor nerve supplies the all the this external extraocular muscles, like levator palpebrae superioris, then the inferior oblique, and the superior rectus, the medial rectus, and the inferior rectus. These are supplied by the cranial nerve 3. That is the oculomotor nerve. The later parts, the exceptions are the superior oblique and the lateral rectus. So we have to know what are the nerve supply of the lateral rectus and the superior oblique. The lateral rectus is supplied by the sixth cranial nerve, that is the abducens nerve. Abducens nerve supplies the lateral rectus. We can remember this as a mnemonic LR6. LR6 means lateral oblique supplied by the sixth cranial nerve. Which is the sixth cranial nerve? That is the abducens nerve. And the superior oblique is supplied by the fourth cranial nerve. That is the trochlear nerve. We can remember this as a mnemonic SO4. So, this superior oblique is supplied by the fourth cranial nerve. That is the trochlear nerve. Here, the question was, which muscle movements are related to the abducens nerve? Abducens nerve means sixth cranial nerve. That is, we know the mnemonic LR6. Then which muscle is supplied by the sixth cranial nerve? That is the lateral rectus. So the answer is lateral rectus. Then the next question, which substance is involved in the conjugation process in the liver? So the options are hyaluronic acid, the glucuronic acid, gluconic acid, glycolic acid. So we have to know the conjugation happening in the liver. First, the hemoglobin, which contains heme and globulin, globin, and this after the RBC, uh, it fragment and releases the hemoglobin, and it divides into heme and globin. The heme part comes and it is converted into the biliverdin by the enzyme hemooxygenase, and the biliverdin is converted to bilirubin, the unconjugated bilirubin, by the biliverdin reductase. Biliverdin is reduced into the bilirubin, and the unconjugated bilirubin reaches the liver and it is conjugated. Conjugated means a substance is added to the bilirubin. Bilirubin plus one substance is added and it is get conjugated. Which is that substance added? It is the glucuronic acid. Glucuronic acid is the substance added to the bilirubin and it got conjugated. So, the UDP glucuronine transferase is the enzyme mediating this process, and the molecule is glucuronic acid. So, the conjugation with glucuronic acid is called glucuronidation. Glucuronidation. And so the answer is glucuronic acid. Look at the other options like hyaluronic acid. It is a component of extracellular matrix not involved in the liver conjugation. Next, the option is option C is glucuronic acid. Glucuronic acid is used in the food industry and not involved in detoxification. Next option is glycolic acid. It is found in skincare, not a hepatic conjugating agent. So the answer is glucuronic acid. So the glucuronic acid is involved in the conjugation process in the liver. Let's revise it once more. The heme, which is oxygen, which is under the control of the hemoxygenase, is converted into biliverdin, and it is under the enzyme biliverdin reductase is converted to unconjugated bilirubin. This unconjugated bilirubin reaches the liver, and it is conjugated with the help of UDP glucuronide transferase and a molecule called glucuronic acid. Glucuronic acid is added to the bilirubin and it is get conjugated. And this conjugated bilirubin reaches the intestine and it is the glucuronic acid is removed and this again became the unconjugated bilirubin and this urobilinogen is converted in is released in the urine and stercobilin is released to the feces and it gives the yellow color to the feces. So that's all about that question. And we are moving on to the fifth question. Look, the fifth question is the 7-year-old child of short stature presents with skin patches and learning difficulties. And the diagnostic workup indicate a defect in the DNA repair specifically related to double strand breaks. And what is the most likely diagnosis? The options are Bloom syndrome, the seroderma pigmentosum, cocaine syndrome, Lynch syndrome. So, first option is the Bloom syndrome. What are the features of Bloom syndrome? There are growth retardation, photosensitive rash, the immunodeficiency causing recurrent infections, the cancer predisposition like leukemia and lymphomas. There is a DNA repair defect. The defect of repair of double strand breaks, these are the indicators we have in the question also. There is short stature, that is the growth retardation we have mentioned, and there are skin patches that may be the photosensitive rashes, then the learning difficulties, and the diagnostic workup shows the defect in the DNA specifically related to the double strand breaks. We have this here double strand breaks and the photosensitive rash, the growth retardation leads to the short stature and immunodeficiencies. So, this question indicating the Bloom syndrome. So, let's discuss about the other options. The second option is Steroderma pigmentosum. What is this? What is the defect in the DNA? There is a nucleotide excision repair defect in the nucleotide excision repair. This is a UV-induced damage and it causes early skin cancers. And then the next option is cocaine syndrome, the defect in the transcription coupled nucleotide excision repair. There is a defect in the transcription coupled nucleotide excision repair. This causes growth failure, neurodegeneration, but no cancer predisposition. Then, about the Lynch syndrome, it is a DNA mismatch repair, not the defect in the repair of double strand. In the Bloom syndrome, there is a defect in the repair of DNA double strand breaks. So in the Lynch syndrome, it is a DNA mismatch repair defect and it causes colorectal cancer, endometrial cancer, ovarian cancers. It is not a pediatric or it is not associated with any growth delays. So the answer to the question is Bloom syndrome. Here we have this short stature, butterfly rashes or skin patches, learning difficulty, and the DNA workup showed DNA repair, specifically the double strand breaks. So the answer is Bloom syndrome. Moving on to the next question. Sixth question. Which of the following deficiencies causes the follicular hyperkeratosis? The answer is vitamin A. It causes the follicular hyperkeratosis. The deficiency of vitamin A is in the eyes is classified as XN. The N denotes the night blindness. X1A means 1A denotes the conjunctival cirrhosis. We can see the conjunctival cirrhosis. This is the the dryness of the conjunctiva. We can see the conjunctiva is dry. Next, there is 1B is bitter spots. We can see a foamy triangular shaped lesions in the malignant temporal part of the eyes. That is the bitter spots. The foamy white triangular patch is the uh, bitter spots. Then X2 is corneal cirrhosis. Cirrhosis means the dryness of the cornea. Dry is the cirrhosis. And the third is here we can see the dryness in the cornea. This is the corneal part, and we can see the dryness in the cornea. And next is 3A and 3B. 3 means X3 indicates the ulceration in the cornea. Ulceration in cornea. If 3 X3A means less than one third of the cornea is affected. Less than one third of the cornea is affected. If we are less than one third of the cornea is affected, they're having an ulceration, it is X3A. If more than one third is affected, it is X3B. That is the corneal ulceration. Then we have the X, that is corneal scarring. Then in xerophthalmic fundi, there the fundus changes happening due to the xerophthalmia. So the hyperkeratosis is caused by the follicular hyperkeratosis is caused by the deficiency of vitamin E. So moving on to the next options, vitamin C causes deficiency causes scurvy, that is bleeding gums, fatigue, poor wound healing. That are the uh, that are the uh, symptoms of vitamin C deficiency. And the deficiency of vitamin E causes neuromuscular problems. Problems like ataxia, peripheral neuropathy, and vitamin C, B6 deficiency. The next D option is vitamin B6 that causes glossitis, cheilitis, peripheral neuropathy. What is this glossitis? That is the tongue. Tongue is inflamed. Cheilitis means the lips are inflamed, and it causes peripheral neuropathy also, B6. And E causes neuromuscular problems like ataxia and peripheral neuropathy. Moving on to the next question. What is the nutritional deficiency commonly associated with chronic alcoholic with a pruritic eczematous rash on the neck? So the neck and the dorsum of the hand. So we have the eczematous rash on the dorsum and rash on the eczematous rash on the neck and dorsum of the hand. The dorsum of the hand is involved, and in the neck also they are having lesions. So what deficiency is causing this? It is a deficiency of vitamin B3, that is niacin. Vitamin B3 is niacin, B1 is thiamine. Okay, this is caused by the deficiency of vitamin B3, that is the niacin. What are the symptoms caused by the deficiency of vitamin B3, that is the niacin? It is pruritic eczematous rash, especially in the sun-exposed areas, like in the neck we are having the we will wear the shirt, but this part is exposed. So we have Kessel's necklace. The lesions are like a necklace, like they are wearing a necklace. So it is the Kessel's necklace, and eczematous pruritic rash, especially in the neck and the sun exposed areas in the hands and forearm. Okay, that is the dermatitis. There is 3D uh, in the symptoms of vitamin B3. That is the niacin. There are First one is the dermatitis. That is the pruritic eczematous rash in the sun exposed areas, especially in the neck, and that is called the what? Kessel's necklace. Next is the on the hands and forearm, and diarrhea is next one is the diarrhea, which is often chronic, and then dementia. There is irritability, poor concentration, and progressing to confusion. The other signs of vitamin B3 are glossitis, photosensitive rash, then hyperpigmentation, and scaly skin on pressure areas. On pressure areas, there will be scaly skin in the pressure areas. These are the clinical symptoms of vitamin B3. That is niacin. Mm. Then the other options are vitamin B1, that is the thiamine. It causes the Wernicke-Korsakoff syndrome, that is that affects the nervous system. And wet and dry beriberi, and there will be no rash in the vitamin B1. But in the question we had rashes in the neck and the dorsum of the hand. And next option is vitamin D. It causes bone pain, rickets, osteomalacia, but not dermatitis. And moving on to the D option, it is vitamin C, and it causes scurvy and bleeding gums and petechiae, not the eczematous rash. The eczematous rash is seen in the vitamin B3, that is niacin. Okay, moving on to the next question. That is a 50-year-old male presented with right-sided serous otitis media with a history of cervical lymphadenopathy. What may be the probable diagnosis? The probable di- the In this question, we have a middle-aged man, a 50-year-old man, and he's having a unilateral serous otitis media, and cervical lymphadenopathy is there, and no obvious upper respiratory tract infections are not there. The most likely diagnosis is a nasopharyngeal carcinoma, particularly when the adult present with recurrent or unilateral medullary effusion, that is serous otitis media, The answer will be nasopharyngeal carcinoma. Why it is nasopharyngeal carcinoma? It can obstruct because in the nasopharyngeal carcinoma, it can obstruct the eustachian tube. The eustachian tube and the nasopharyngeal carcinoma can obstruct the eustachian tube and causes the drainage of the uh, s- serous product of the middle does not occur, and it causes the serous otitis media, which may be usually it is unilateral, and leading to the buildup of the fluid behind the tympanic membrane and serous otitis media occurs. And cervical lymphadenopathy is the often the first sign of this nasopharyngeal carcinoma. It is often asymptomatic nasally until later stages. Nasal complaints will be absent. Why not others? Why it is not angiofibroma? Why it is not angiofibroma? Because it is seen in adolescent males. That is, it is also called juvenile nasopharyngeal angiofibroma. Juvenile, it commonly affects the adolescent males. Adolescent males, and it presents with epistasis. The main complaint is epistasis. That is the blood coming from the nose. That is the main complaint of the angiofibroma, and rarely it causes any serous otitis media. And next option is adenoid hypertrophy. Hypertrophy is more common in children. It is unlikely in a 50-year-old man. And next option is the tonsillar abscess. It presents with throat pain, trismus, muffled voice, not with otitis media. So the correct option is option B, nasopharyngeal carcinoma. So the next question is a person who was mentally unsound at the time of committing a crime is exempt from the liability if they were unaware of the nature of their action or its consequences. What is this principle called? It is McNaughton rule. McNaughton rule. What is McNaughton rule? It is a legal principle used to determine whether a person can held criminally responsible for their actions due to insanity or mental unsoundness at the time of committing a crime. If the that in simple terms, that if the person is mentally unsound at the time of committing a crime, he is not criminally responsible for the act of crime. And it is called the McNaughton rule. The other options are Durkheim's rule. Durkheim's rule is a if a person is not, it states that if a person is not criminally responsible if the act was a product of mental illness. If the criminal act was a product of mental illness, it is not, the person is not criminally responsible. That is called Durkheim's rule. Next is the currents rule. Currents rule it focuses on lack of substantial capacity to appreciate wrongfulness or confirm behavior. Uh, that is the currents rule, and irresistible impulse test is the next option is the irresistible impulse test. The person knew the act was wrong, but he was unable to control the impulse. He knew the act was wrong, but he can't control the impulse to commit the crime. That is the irresistible impulse test. So the answer to the question is McNaughton's rule. McNaughton's rule. That is, the person who was mentally unsound at the time of committing a crime is exempt from the liability if they were unaware of the nature of the actions or its consequence. If he was unaware of the nature of their action because of the mental unsoundness. This principle is called McNaughton's rule. Then the next question is, acute liver failure is a clinical feature of which of the following? First option is OP poisoning. What are the symptoms of OP poisoning? In the question, they are asking the acute liver failure. Acute liver failure. But first option is OP poisoning. In OP poisoning, what are the symptoms? There are nicotinic and muscarinic symptoms. In the nicotinic symptoms, the OP poisoning, that is the organophosphorus poisoning, presents as diarrhea. There will be more excess urination, meiosis, that is the pupil get constricted. The constricted pupil, that is the pupil. Pinpoint pupil is a symptom of organophosphorus poisoning. Then the bradycardia, bronchospasm. It causes the bronchospasm or bronchoria. That is more secretion of this mucus in the bronchus. That is the bronchoria. Then E is the excitation of skeletal muscles and CNS. Then L is lacrimation. That is more secretion of tears. Then salivation, more secretion of saliva. Then sweating, that is the sweating of increase in sweating. These are the symptoms of organophosphorus poisoning. So here we didn't see any complaints like acute liver failure. So the organophosphorus poisoning do not cause acute liver failure. The next option is belladonna poisoning. What are the symptoms of belladonna poisoning? There are delirium, that is the mental symptoms that are delusion, excessive sensitivity, and liquid and abhorrence, then imagination, rage, anger, inclination, suicide, then unnatural mania, then uh, and mania delirium. We can remember it as delirium, that is delusion, excessive sensitivity, liquid abhorrence, then high for imagination, rage and anger, then rage and anger, then the inclination, that is suicide, then unnatural mania, maniacal delirium. Then we can the symptoms which are get into the belladonna poisoning, that is the congestion, redness, heat means the temperature will be high, and burning sensation while of the tract, and burning sensation, then the dryness, pain, sensitiveness. So we didn't see any acute liver failure. The liver failure is not caused by the belladonna poisoning. The next option is morphine poisoning. Morphine side effects are drowsiness, the constipation, nausea, itching, difficulty in urination, muscle aches, insomnia, and coma. So we didn't see any acute liver failure in any of the OP poisoning, belladonna poisoning, or morphine poisoning. So the answer, the exception is Amanita phyllodes poisoning. So let's look at the Amanita phyllodes. It is also known as the dead cap mushroom. It is the most hepatotoxic natural poison known, and it causes liver failure due to the amatoxins, which inhibits the RNA polymerase 2 and causes the hepatocyte death, and it causes liver failure. What are the phases of Amanita phyllodes poisoning? It causes First stage is the latent stage. Latent phase, it is asymptomatic. Then the gastrointestinal phase, there are severe vomiting, diarrhea, dehydration. Then hepatic phase, it happens after 2 to 4 days, and it causes the hepatic failure. Then jaundice, coagulopathy, elevated transaminases. These occur in the hepatic phase, and then the recovery phase or death can happen after 4 to 5 days, depending on the treatment and severity. So the answer to the question is acute liver failure is a clinical feature of Amanita flowers poisoning. Amanita flowers poisoning. Then next question onwards we are discussing in the as a next part. So thank you for watching and subscribe for reaching the next